Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor of MedEvidence. And I always love to interview a kindred spirit, and I have a kindred spirit today, Dr. Manish Jain, who is a clinical investigator out of the Chicago area. He's braving the cold temperatures there. We were just talking about that. But we're excited that you found a warm spot to talk about something that's warm in both of our hearts, which is how to reach out to your community and talk to people about clinical research. So, one, welcome to MedEvidence. And two, why don't you just introduce yourself to our audience and tell us a little bit about yourself?
Yeah, definitely. My name is Manish Jain. I am a board-certified rheumatologist and internist, and I run a busy private practice on the north side of Chicago. We take great care of our Cubs fans. If you're a White Sox fan,
you're in big trouble.
And so, yeah, it's me and really a wonderful clinical team. And then beyond that, I also serve as a principal investigator, and I'm really based at our research site, which is adjacent to my clinic. I'm also the regional medical director for Flourish within our Midwest region. So I help oversee now a handful and a growing handful of research sites here in the Midwest.
Yeah, and I will state that I love White Sox fans. So you can find somebody that loves everybody in our organization. So that's a great introduction. Thank you. So how'd you get involved in clinical research? What was the impetus?
Yeah, so, I had been interacting with a standalone research center, this is maybe 8-10 years ago. And so participating as a principal investigator really in studies that were, kind of bread and butter for a rheumatologist to participate in. Think about a study for, a new agent for rheumatoid arthritis or, a new agent for gout, osteoarthritis. These are kind of the bread and butter conditions that I see as a rheumatologist. And, I kind of started off doing it as a little bit of a hobby. It was just like a fun thing for me to offer to patients and just kind of kept things exciting for me in clinic. And so I did that for a while, and then COVID happened, and then everything just changed, right? It changed for all of us, changed for our patients, changed for our colleagues alike. So during COVID, a lot of the, especially kind of really early on when the pandemic was at its fiercest, a lot of our patients suffered in the hospital with really serious forms of inflammation in their body, especially in their lungs. And so pretty early on, many of the medicines I use as a rheumatologist were of high interest to kind of help fight that inflammation brought on by COVID. And so it kind of a, weird, wild story. One of the agents was actually a JAK inhibitor, Janus activating kinase inhibitor. We were studying it in rheumatoid arthritis. And so an opportunity presented itself to perform a study with the same drug, but in an inpatient setting for COVID patients. And so basically, myself and a handful of resident physicians, training physicians, banded together. And during the height of the pandemic, when we really just didn't have a lot of options to offer our patients, we didn't have any clinical trials going on at our kind of smaller community hospital, we enrolled 55 patients in the hospital. So that was kind of a big inflection point and really helped me kind of understand the power of clinical trials in just a really, really, different way. And just how, even though my lane is sometimes a little bit narrower as a rheumatologist, how really it can be applied more broadly to all of our patients in need. So that's my story.
Well, that's interesting. So I'm in suspense. Did the JAK inhibitor work for COVID patients?
It did. It actually reached an FDA approval. I was really proud to see a drug from its inception, even helping a sponsor, come up with how to study the medicine, by giving input, and seeing it all the way to an FDA approval. Really a very special,
very event. Exciting. That's fabulous. So how long did it take you to get comfortable approaching patients about research? And do most patients look at you skeptically when you present this concept to them, or how do they respond to you? So I bring this up because a lot of physicians are just intrinsically uncomfortable with approaching patients about research opportunities. And that's a very important part of the skill set of an accomplished clinical trial professional.
Yeah. I see a lot of synergies with how I talk to a patient in clinic. I might be presenting them, a new therapeutic option. And I'm going to present pros and cons, risks and benefits. And I lean on that experience quite a bit when I'm speaking to a patient, about a clinical trial. Many times, not all the time, but many times, these are patients whom I've had a years-long relationship with. I know their families. I know just a lot about the patient. Not all the time, though. Sometimes it's a new patient I'm presenting it to. But I think just having a really honest, transparent discussion, I think knowing what I'm talking about is also really important. Just like I need to know what I'm talking about when I'm presenting a drug, in clinic. I need to know what I'm talking about when I'm presenting a trial to a patient. Be able to field questions and not just turf them to another team member. And I think really just understanding where the patient is coming from, what motivates them. Many of my patients are driven by altruism. They want to help. For example, if I have an immunocompromised study, many of my patients will sign up for it because they want to help everyone who's immunocompromised.
Yeah.
So just like in clinic, understanding the patient's value system and understanding if and how a trial can kind of fit that value system.
Do you have any things you can share with us on how you can assess that? Any little turns of phrases or ways that you get clued into what would drive a patient and get them interested in clinical research?
Yeah. So I think first it's like just identifying the clinical need. If I have a patient in need, the need could be for so many reasons. They don't have access to a certain treatment. The need could be that, this is really something new for them. So understanding that need and then really tying how I speak to a patient based on that need. So I'll just give an example. One of the bigger studies I had enrolled into was not looking at a vaccine. It was looking at something a little bit different, a monoclonal antibody. So it's a monoclonal antibody that would help potentially protect patients against an infection. In this case, it was COVID. And so helping explain to a patient, vaccines are super important for my immunocompromised patient, but vaccines don't always uptake quite as well. They don't always work quite as well in my immunocompromised folks just because it might be the disease itself. It might be the medication that I'm required to use.
Right.
And so helping my patient understand, well, listen, this is a way to potentially supplement that vaccine response. So I think, understanding, and that was quite motivating for a lot of my patients. So I think understanding where they're coming from, explaining it in lay terms, and leaning on kind of my experience as a clinician and having discussions with patients. That's what I've used.
Right. Yeah, and there are also social situations for people. Either people are struggling with their finances or people are having difficulty affording a certain medication. Often that can drive our discussion with regard to why a patient might be interested in something that we're doing.
Absolutely. And even something as simple as transportation. I'll have patients who, they'll come see me on my clinic side. And unfortunately, I cannot provide transportation for a patient when they're coming to see me for a clinic visit. We can provide it often in the context of a clinical trial visit. And so, sometimes I have to remind my patient, you're here for a clinic visit today and not a clinical trial visit.
Yeah. So just for the audience, when we run clinical trials, we compete for grants, and the grants include stipends, often for patients, including their expenses. And sometimes the stipends can be used for other medications that are important for them to be on as part of the research. So there's a lot of opportunities that we have a little discretion over, not complete discretion, but some discretion.
And the other thing that I'll lead on a lot is helping patients understand all the close monitoring that they're going to receive. I'll give one example. We had a patient enrolled in one of our cardiovascular studies. This wasn't my practice patient, but it was a patient of a close colleague of mine who's a cardiologist. And so we were just doing like a standard phone checkup on this patient. I have a really smart physician assistant on the research side who just picked up the patient just sounded a little short of breath, just didn't sound right. And so that patient was actually in the midst of a flare of their congestive heart failure. And I was picking it up over the phone. And the patient just didn't have the opportunity yet to bring it up to his cardiologist. But we picked up on it first, and that patient went right away to the emergency room. So that's just one example. But this happens day in and day out in our practice.
Yeah, that's a great point. And an ancillary point is that when you develop a skill set as a clinical trialist, it kind of overlaps your therapeutic expertise. So I'm a cardiologist, and like you, I was involved in the COVID trials, mostly the COVID vaccines. And it's not because I was an expert in virology or infectious diseases or vaccines. It's because I knew how to run clinical trials. And all of a sudden, we had to scale clinical trials where we're putting hundreds of people in a very short period of time as part of Operation Warp Speed. Both you as a rheumatologist and me as a cardiologist are sometimes doing the same studies, but we can bring different things to the table. So, for example, I know that we're both involved in lipid studies, looking at, for example, lipoprotein little a, which is a form of LDL cholesterol that seems to be particularly atherogenic and runs in families. And so how do you as a rheumatologist talk to people about something that may be a little bit different than what you would talk about in the clinic, but is relevant in terms of your skills as a clinical trialist?
Yeah. And the way I look at Lp(a) is we may not be talking about in clinic, but we ought to be. So this was a real evolution kind of in my thinking and just frankly, my education as well. So we know that, my patients with rheumatic disease, let's just use rheumatoid arthritis as an example, are at a much higher risk for cardiovascular disease. So we actually think of rheumatoid arthritis as probably a diabetes level risk for the formation of heart disease. And we ought to be talking about our patients about modifiable risk. We ought to be talking to patients about statins. We may not be managing their statins in a rheumatology practice, but we should be eyeballing their medication list and say, hey, you got to talk to your primary care doctor and see if we can get you on this risk mitigation treatment. So when it comes to something like Lp(a), it's actually really fun for me in clinic to bring it up to a patient. And, I kind of describe it as, maybe it's like a stickier cholesterol and it's been tied to, these bad outcomes. And it's something that we don't think you can diet or exercise your way out of. But it probably does drive a lot of the risk for bad events. And up till now, didn't really have anything to offer other than, just checking it. But that's changed in the context of a clinical trial. Not only can we check it, know your number, know your risk, but we may be able to do something about it in the context of a study. And so when I present it to patients like that, they're usually very excited to not just have the level checked, but if it's high, to think about doing something about it.
Yeah. And then another area of overlap is the concept of inflammation. You talked a little bit about that before, but it's been well known that patients, for example, that have rheumatoid arthritis are at higher risk for cardiovascular events compared to matched patients that don't have rheumatoid arthritis. So is that an area of focus or concern, or how do you express that to your folks?
Yeah, so quite a bit, right? We know that our patients who have tighter disease control for their inflammation, for their rheumatoid arthritis, over time have better cardiovascular outcomes. Study after study has shown that. So that's another opportunity to engage a patient, either in clinic, maybe in a clinical trial, that your rheumatoid arthritis is uncontrolled. You're on a ton of prednisone, as an example, which we know is connected to cardiovascular risk. And we've got to get this disease under control, be it through an agent that's FDA approved, that I've got access to samples in my fridge, or be it through a clinical trial for rheumatoid arthritis, just as an example. So really helping patients kind of understand, I'm something I'm very fond of telling my patients in the clinic, like, I care about your pain. I do. I care about it. What I really care about is all this systemic inflammation. I care about your heart attack risk, your infection risk over time. And my job is to really help stamp out this inflammation and help mitigate risks while I do it. So that's something where, again, my practice and my trial practice align.
Yeah, and that's an important holistic view. And so, interestingly, and perhaps counterintuitively, even though we may be focused on one question when we do clinical trials, we actually have to think about patients holistically. So as you point out, people that have inflammatory conditions such as rheumatoid arthritis may be at mortality risk from cardiovascular events. And by talking to them about that, you're actually taking a very holistic view of the patient.
Yeah, absolutely. I think my passion in life, right, why I feel like I was put on this earth, was to improve the lives of my immunocompromised patients. 10 years ago, I think I had a kind of a myopic view of that, right? I was going to improve their lives within the context of the medicines that I, as a rheumatologist, classically would prescribe. But now my perspective is so much different, right? I still am prescribing those medicines, and I'm getting their disease under tight control, but I'm also thinking about their BMI. I'm also thinking about their lipids. I'm also thinking about their vaccination status. I'm also thinking about, have they gotten up to date on malignancy screening? So these are all ways that I'm convinced that the trials have made me into a better clinician.
Yeah, and that's very, very well said. So I'm going to switch gears on you a little bit. And I also know that you're passionate about physician education. And in fact, you're going to join me here in Jacksonville in April to do a physician training course on how to become more effective as a clinical trialist. And of course, teaching doctors who may not be that familiar with the concept of GCP, or good clinical practices, what that means. And that is one of the elements of the skill set that a good clinical trialist has. There are many other elements that we get into during the course. So just tell us a little bit about how you got interested in the physician training piece, and maybe some of your strategies on how physicians learn best.
Yeah, absolutely. I love teaching. It's been a part of my career for quite some time. So actually, before I got really busy with clinical trials, I participated quite a bit in resident education. I was actually a program director for a transitional year program. That's a training stopping point for a future radiologist or dermatologist. And being able to lecture about rheumatic diseases, I think sometimes some of my conditions kind of are they almost feel a little mystical or confusing even to medical trainees. And so demystifying it, helping our docs understand how to recognize and refer, or maybe even take care of, patients with our conditions is always been a fulfilling part of what I do. It's really fun for me now to bring in the clinical trial aspect into that and teach, training doctors about, well, okay, you're prescribing this medicine. How did that medicine come about? Helping them understand how to read a study, right? What are you supposed to look at when you're evaluating a study? What are some of the questions you should kind of poke at a little bit when you're evaluating a study? So I'd say being able to kind of educate trainees on the clinical trial process and just how to critically evaluate data as it comes out, super fun, super fulfilling for me.
Yeah, that's a great point, is that it may be a bit of a lost art, but reading a technical journal publication is something that not all physicians are particularly good at. Mm-hmm. And once you have some clinical trial experience, you get much better at that. Yeah. And it really enhances your understanding of the particular project, the hypothesis that's being tested, the therapeutic area, and also the interface between your patients and what they can get out of the latest and greatest in that therapeutic area. So I think we do spend a little bit of time on how to read the literature during our training program.
Yeah, absolutely. It almost, when you get kind of involved in this clinical trial world, you really get this very foundational, fundamental, in-depth understanding of the studies. And, it's almost like you almost, you start following studies like you start following sports if you're an avid sports fan. You
Right.
really know the ins and outs of them. And you bring that back into clinic on a day-to-day basis. And that's really fun, as being able to close that loop for patients.
Yeah, absolutely. And this next question may reflect my bias, but how do you feel about this standard of training, quote unquote, and I put that in big quotes, where somebody says, okay, look at this website, doctor, and listen to it for 30 minutes, and then you're trained, versus some of the experiential training that we typically did back in residency and fellowship, and what I believe is a great way to train people after our, quote, formal training.
Yeah, so I saw the evolution of medical training and kind of the change of what it's turned into now during my medical training. I mean, we were kind of from 06 to 09, kind of the trailing end of the last days of the Giants, where, you had the, overnights in the hospital, 30-hour training shifts. And it wasn't to say that it was all good, right? I mean, there were some negatives there. I was tired, and but really, I think, like, I'm really thankful that I had that opportunity. I don't think I'd be the same doctor if I had trained, if I didn't have that opportunity during my training, to have those long nights bleeding into days, and to kind of be able to care for my patient with that continuity.
Yeah. No doubt. We were just talking about that earlier today, that, when I was training, being on call every other night for months at a time was not unusual. And we had shifts up to 36 hours. And that part of medicine, from a training perspective, has gone away. And I think probably for the worst overall. Although, to your point, we don't need people necessarily absolutely fatigued making important decisions, but there's ways to deal with that. But getting to the more broad question, in clinical research, what's the most effective way to teach other people to get up to speed, in your opinion?
Yeah, I think it's got to be multimodal. And so I think there's a role for modules and, standardized, formalized training. There's a role for, lectures. There's definitely that's, I think, a core component of the foundation. There's a role for doing as well, to be that investigator, to perform the assessments, to have that direct patient-facing contact as well is really important. But I think there's that third pillar that has, for me, helped make me the investigator I am today, and that's mentorship. And it's sometimes hard to find mentorship within clinical trials. For me, that's been, I think, one of the most exciting things about being part of a clinical trial network like Flourish Research is that I don't just have access to amazing patients and amazing studies, but I have access to amazing mentors. And that has just been really, really important and a big driver of my growth over time.
Yeah, no doubt. The concept of mentors has been extraordinarily important for me. And to your point, when you're just looking at online modules, you don't get that sense. And there's very many softer points of being effective as a clinical physician and as a clinical trialist that you're just not going to get other than through experience and watching how other people do things and finding your niche. You don't have to do exactly things the way your mentor did, but at least you see different styles, and that eventually helps you develop a style that you get really comfortable with and get really good at. So I think that's super important. So Manish, this has been a fabulous conversation. Before we sign off, are there any other major things you'd like to share with the audience with regard to your career experiences, your interfaces in clinical research?
Yeah, to me, I think it's all about the synergy. I really lean on the things that I hope make me a strong clinician. I think directly carry over into being an investigator. There's definitely differences as well. But to me, I kind of see it's more about the synergies and similarities of the two. And I guess the last other closing thought I'll leave you with is it's super fun. I think Dr. Koren, you and I both have some colleagues that maybe aren't having as much fun as they ought to be in practice of medicine, right? I think we see high rates of medical burnout, just as an example in our profession. I really think to get to participate as an investigator and kind of carry these dual roles like you and I do, it's really fulfilling. And I think we wake up just with a lot of purpose and a lot of excitement and ready to tackle the day. And for that, I'm truly thankful.
Yeah. And you alluded to this, but part of our medical culture as old school physicians is that we do clinical practice, research, and teaching. It's all part of this trilogy that are very, very important to us, that fulfill us as physicians that want to be a cut above other people. And research is a big part of that.
Agreed.
So, Manish, this has been a great interview, and I just want to say that we'll have some show notes that give people information about how they may want to participate in our training session coming up at the University of North Florida in April. And so we encourage people, physicians, this is really physician-focused, to look into that and learn more from folks like us and other members of our educational group that will be talking about the many, many elements of clinical research that you may want to get involved with. Or if you've been a little involved with, you may want to make your skills get to a higher level through this type of interaction. So again, I'm excited to work with you at the University of North Florida in April. We'll have more information on the show notes, and thank you so much for being part of MedEvidence.
Thanks for having me. Really appreciate it.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.